Thank you, Krupa. We'll move to the next presentation from Medicine 1, Dr. Lino. His topic is the fountain.
So good morning, everyone. My topic for today's presentation is the fountain. I'm presenting on behalf of Medicine 1. Presenting Mrs. X, 43 years old school teacher from Assam, presented with increased thirst for 5 months, increased frequency of urination for 5 months. She was apparently well before 5 months, then developed increased thirst and dryness over the oral mucous membrane, which is relieved by taking excess water, preferably cold water. She also reported increased frequency of urination with a nighttime voiding frequency of 3 to 4 times per night. She had maintained a voiding diary that showed a daily urine output of around 10 liters. So past history is there is no previous history of head trauma, no history of snake bite. She was diagnosed hypothyroidism before 8 years on L-Traxin 50 microgram. Personal history, there is no addiction, mixed diet, sleep was normal, appetite was normal, her bowel and bladder habits were normal. The obstetric history wise, she had 2 first-timer abortions and 2 stillbirth. And in 2018, the stillbirth, she had 3 liters of blood loss. And in 2013, she had a live birth, after which she breastfed for around 9 months. Examination at time of presentation showed blood pressures of 120/80, her pulse rate was 76 per minute, which was regular, respiratory rate of 18 per minute. There is no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or edema. Respiratory system examination was normal. Cardiac examination also normal. Abdomen examination also normal. Central nervous system examination showed a normal cranial nerves. The visual field by confrontation test was also normal. Fundus was normal. Extraocular movements were normal. Facial sensation were normal. Tongue convolular center, shoulder sarcoidal normal. Other system, motor system, sensory system examination were also unremarkable. There is no cerebral signs. Skull and spine was also normal. So summarizing, this is a 52 years old, 43 years old school teacher with a known case of primary hypothyroidism and L-Traxin supplementation. Now presented with polyuria and increased frequency of urination for last 5 months with no remarkable examination findings. With this, we evaluated in the baseline investigation showed a HB of 12.4 and platelets of 8,56,000 with a total counts of 9,800. Renal function test, creatinine of 0.67 and liver function test showed a SGOT of 21, SGPT of 18, alkaline phosphatase of 119 with a total bilirubin of 0.53. Her serum electrolytes reports reviewed a high normal sodium of 144 with a potassium of 4.3 and bicarbonate of 23, and also her HbA1c was 5.3. And urine routine examination revealed no WBCs or RBCs in urine with a specific gravity of 1.003. And her urine osmolality is 54, suggesting a dilute urine. So this is a 43 years old female with a past history of hypothyroidism, now presented with polyuria for 5 months, associated with increased thirst, with the examination finding suggestive of a dilute urine. So what are the likely differentials? Yes. We were also thinking about the same differential and we evaluated the patient further. So what is polyuria? So when when your 24 hours urine output is more than 3 liters or more than 40 ml per kg per day, we call it as polyuria. In children, it is more than 2.2 liters per meter square. So there are two types of polyuria. Polyuria can be due to it can be of solute diuresis or secondary to water diuresis. So what is solute diuresis? In solute diuresis, there will be excretion of non-absorbable solutes, preferably glucose in hyperglycemic state, uremia in mannitol, patient treated with mannitol, and those receiving high protein feeding. And we also see in post-subtractive diuresis and in resolving ATN and diuretic therapy. In this, the patient will have a urine volume of more than 3 liters per day. However, urine osmolality will be more than 300. Where other case like water diuresis, where the excretion is predominantly urine excretion, and it is most likely secondary to arginine vasopressin deficiency, or it can be due to its resistance, or it can be due to its excess breakdown, or it can also even secondary to primary increase in water intake. In this, the urine volume will be more than 3 liter per day with the urine osmolality less than 300. So water diuresis can be 4 types. Can be central diabetes insipidus. It's secondary to the absent or subnormal arginine vasopressin secretion due to the hypothalamic or pituitary damage, posterior pituitary damage. It can also be due to nephrogenic diabetes insipidus. In this, the secretion will be normal. However, there will be impaired renal concentrating ability due to the renal condition where the arginine vasopressin will be arginine vasopressin binding to the V2 receptors, or more commonly have attenuated activation of G protein signaling and aquaporin 2 generation after receptor binding. Basically, the secretion will be normal. There will be resistance for action of arginine vasopressin. In third case is primary polydipsia. In this, patient will have excessive thirst appreciation. Primary disorder of excess thirst appreciation. It is associated with psychological or psychiatric conditions, and even in occasionally structural intracranial abnormalities are associated with this. The fourth entity is pregnancy associated diabetes insipidus. In this, placenta, in placental production of vasopressinase will be enzyme will be this vasopressinase has tendency to break down arginine vasopressin, thereby causing deficiency of arginine vasopressin, especially in the second or third trimester of pregnancy. So how do you evaluate polyuria? First, by history and bladder diary, we confirmed the polyuria. Our patient had more than 3 liters of 24 hours urine. And then we did a urine osmolarity. We showed a urine osmolarity of more than less than 250. If it is more than 300, as I told before, it's most likely secondary to solute diuresis, such as in hyperglycemic state, those treated with mannitol and received radio contrast in uremic state, and resolving ATN and obstructive diuresis. In case patient is having urine osmolarity less than 250, that signifies there is a problem in renal concentration of urine, concentrating capacity of urine. There we will evaluate further. In our patient, has urine after admission, her urine output is noted to be more than 10 liters per day, and her urine osmolarity was only 54. So, and further evaluation, how do we proceed is we can do a water deprivation test, or we can do baseline plasma copeptin levels followed by hypertonic saline infusion test. Water deprivation test is a gold standard, and we did water deprivation test for our patient. In during dehydration phase, patient her initial serum osmolarity at the start of test was 296 with a urine osmolarity of 53 and a serum sodium of 141. Her urine output was 300. After every 1 hourly we checked the morning vitals, and 2 hourly we repeated the urine osmolarity, serum sodium. At 10 o'clock, the urine osmolarity was repeated. It was 64 with a serum sodium of 148. The criteria to stop the test was either when there is a 5% drop in weight, or any severe dehydration, or serum sodium more than 148. After 10 o'clock, the patient's sodium crossed 148, and the dehydration phase was with it. And then we administered injection vasopressin 5 units subcutaneously, and we look for a response. At around 11:45 a.m., her repeat urine osmolarity was 64. After 1 hour, the urine osmolarity was repeated. It showed a urine osmolarity of 364. So by algorithm, when water deprivation test is performed, after starting of water deprivation test, if urine osmolarity cross more than 800, it's most likely secondary to primary polydipsia. In that case, we will not continue the test further. If urine osmolarity is less than 300, there is a possibility of either it can be central diabetes insipidus or nephrogenic diabetes insipidus. If it is between 300 to 800, still there is a chance of both central diabetes insipidus and nephrogenic diabetes insipidus, but it can be a partial or complete. So our patient had a urine osmolality of 54 at the end of 64 at the end of dehydration phase, and we administered injection vasopressin. Post administration of vasopressin, we were monitoring urine osmolality every 1 hourly, and there is more than 50% increase in the urine osmolality after desmopressin, confirming the diagnosis of central diabetes insipidus. So what is central diabetes insipidus? It is secondary to loss or impaired function of vasopressinergic neurons in the either in the hypothalamus or posterior pituitary. So there are various etiologies behind the central diabetes insipidus. Most common acquired causes like head trauma, neoplasm involving primary neoplasm in like craniopharyngioma, pituitary adenoma, dysgeminoma, meningioma, even metastatic cancers and hematological malignancy can also present with central diabetes insipidus. Other things like granulomatous disease like sarcoidosis, histiocytosis, infection like chronic meningitis, viral encephalitis, toxoplasmosis can also present with central diabetes insipidus. Inflammatory conditions like lymphocytic infundibulous neurohypophysitis, granulomatosis, polyangiitis, lupus erythematosus, scleroderma, and toxins and vascular causes can also present with central diabetes insipidus. For evaluation, we evaluated the etiology of a patient. Other day mentioned in the protein investigation showed a platelet count of 8,56,000. There is no evidence of iron deficiency noted. Historically, also patient had no evidence of infection. We went ahead with the bone marrow biopsy. It showed a cellular marrow with MAHAC karyocyte hyperplasia. Cytogenetics is yet awaited. Her serum calcium, corrected calcium was normal with a normal phosphate, and ACE levels were also normal. ANA was negative, anti-MPO-PR3 was also negative. We evaluated for other hormones like TSH was normal, FSH and LHS were also normal. Prolactin in dilution was lightly elevated, more than the upper limit, it is 37.3. To look for any pituitary focal lesion, we did a MRI brain, no focal lesion was noted in pituitary, borderline thickening of pituitary stalk was noted. Etiology in our case is yet under diagnosis because this bone marrow is confirmation is not bone marrow cytogenetics awaited. There are case reports suggesting myeloproliferative neoplasms associated with central diabetes insipidus. Other reasonable causes we have excluded. How do you treat central diabetes insipidus is like with desmopressin. Desmopressin is a synthetic analog of arginine vasopressin. It acts selectively in the V2 receptors. It is available in intranasal, oral or injection route. For our patient, we have started oral desmopressin 50 microgram BD. And after starting, her polyuria and excess thirst significantly has come down.
Thank you, Lino. Any questions from the audience? If you could just mention for everyone once again, what are the endpoints for stopping the water deprivation test?
If weight, we should record the weight at the start of test. When weight falls by more than 5% from the baseline, we should stop the test. If any hemodynamic instability, we should stop the test. Or if patient having severe dehydration and if patient is not cooperative, the test also we can stop the test. And in case of sodium more than 148 and serum osmolality more than 299, also we'll stop the test.
Okay, and if there is no rise in the urine osmolality for 3 consecutive instances, in spite of a rising serum osmolality after you administer your desmopressin. Sure. Okay, what etiology are you thinking of for this patient's central DI? Because I think MRI was normal. I think you reasonably ruled out all infiltrative pathologies.
Idiopathic or the hematological malignancy, we're not sure, because bone marrow is.
Okay, lymphocytic hypophysitis.
Yes.
Do you consider Sheehan syndrome in this patient?
But other hormones are normal, and her last pregnancy was like she breastfed normally for.
Sure. Thank you.
Because that can be partial.
Was there PPH in the prior pregnancies?
3 liters of hospital, ma'am, but 3 liters of blood losses, she told, ma'am.
Yes. You may not have a complete, you may get a partial. So you get that history, then I will let you leave it. So I wouldn't know a whole etiology of the blood, and just say,
there's no other questions, then thank you, Lino, for your presentation. We'll move to the next presentation. What to expect when you're expecting from Dr. Trifina. Dr. Trifina is doing her ICU